Bitesized impact showcases. This is the first 4 sessions. My name is Richard Neal from Exeter, and as you can see from outside, it's a lovely sunny day down here in the southwest. We have 3 presentations for you this morning. That's Tanimola Martins here from Exeter, Adam Geraghty from Southampton, and Ben Saunders from Kiel. The presentations are about 10 minutes each and 5 minutes for questions. Just a couple of bits of housekeeping. We have muted you all and turned off your cameras. Please do put questions in the chat, and then Jess, who's here from SPCR, will be monitoring the chat and focusing on the questions. I would strongly encourage you, if possible, that we try to keep the questions and the discussion focused upon impact rather than methods, for example, which I think will be a helpful thing to do. So please put your questions in the chat as we go along, and we'll pick some out for you. The session is being recorded, as you can see, so if anyone wants to see it later on, then they can do. So I think without further ado, I've got great pleasure in introducing my colleague, Tanimola Martins, who's also here from Exeter. He's a senior research fellow, and he's going to be talking about evaluating ethnic differences in PSA for detecting prostate cancer in primary care. So you happy to lead off on that, Tanny? And for the audience, please, questions in the chat as we go along. 10 minutes, please, Tanny.
Thank you. Richard, can you hear me?
I can hear you, and I can see your slides perfectly well, so I assume others can as well.
Excellent, because I can't see anybody. Thank you very much, Richard. A very good afternoon to you all. It's a real pleasure to be here. I just wanted to say a big thank you to the School of Primary Care Research for inviting me. And not just that, but also for providing the funding alongside Cancer Research UK to do some of the work I'm going to be presenting today. The plan is to share with you some of the findings of our work looking at ethnic differences in PSA testing and the impact this has had since publication, and some of our plans to take this further to the next level. Okay, I am confident that many in the audience will be fully aware of the scale of the problem we have in prostate cancer. And it's just good to remind ourselves that around 55,000 men are diagnosed with this disease each year in the UK, and 12,000 of these die from their disease. The risk of death is much higher in older men, and in particular, Black men. And for those surviving the disease, many of them will have to live with some very, very life-challenging complications from treatment. And so this is really a problem requiring urgent solutions. And at the University of Exeter, this is what we're interested in doing. We want to help, provide the evidence to inform solutions to addressing particularly ethnic differences in prostate cancer, which means how it really, really affects Black men. We know that stage of diagnosis matters. Early stage prostate cancer tends to have better outcome. And we know that the biology of cancer itself plays a part in the stage of diagnosis, with Black men more likely to have the aggressive form of the disease. We also know that patient awareness of their risks or early warning signs of the disease may impact on how soon they present to their GP for help. What our evidence suggests from our previous work is that Black men are not less aware of prostate cancer. And as a matter of fact, they are not more likely to delay seeking help. The reality is the fact that men delay seeking help full stop, regardless of ethnic background. But what the evidence shows is the fact that Asian and Black men tend to experience delayed diagnosis. Now, this is an area where we can actually make an impact in terms of clinical practice. We know that once men present to their GP, whether they think they are at risk of prostate cancer or they notice early warning signs, the very first step is the PSA test. That is the prostate specific antigen test. This is a blood test that the GP will perform. They look at the level of the PSA in the blood. If it's high to a certain threshold, they may choose to refer the patient to secondary care for specialist investigation. Now, as you all know, the PSA test is not incredibly perfect. A lot of men will have high level of PSA in their blood, but will end up not having prostate cancer. Some men will have low level of PSA and they will have prostate cancer. So it's not very, very sharp tool. Also, the PSA cannot tell us whether a particular prostate cancer is the aggressive type that requires treatment right now. So that's one thing to notice about PSA. The test is also sensitive to a number of factors, including rigorous exercise, patient age, and ethnicity, as we know. So if you look on the NHS website, there are some preparatory advice for men going for their PSA to not have ejaculation within 48 hours, exercise, etc. I don't know how you can control that in reality. Also, the National Institute of Health and Care Excellence Guidance recommend that GP use the age-specific PSA threshold, again, because of the sensitivity of the test with age. As men old ages, PSA level goes up. What the guidance doesn't include is the fact that PSA values differs by ethnicity. So we published this study, this systematic review, a couple of years back, where we looked at men without prostate cancer and see what PSA means in them. And what we found in that study is that Black men often have higher than average PSA values than men of other ethnic backgrounds. And as you can see there, none of the studies that we found was published in the UK. So what we did in the study I'm sharing the findings today is to look at the patient records of over 700,000 men in the UK, look at their average PSA values, who get prostate cancer, and what stage were they diagnosed. And what we found in the study is that on average, Black men had the highest PSA value. So consistent with the findings from those studies published in the US. What we also found in that study is that once you take into consideration the high level of PSA, Black men were also more likely to have prostate cancer diagnosis, in which case they have higher incidence of prostate cancer than men or of other ethnic groups. But they were not more likely to have higher level of advanced stage diagnosis. And this is really, really important. This is one key question that this study is brought to us all, that is it the case that Black men are more likely to have prostate cancer because of their baseline PSA values, in which case are Black men more at a higher risk of harm due to their higher PSA level than other men? And if this is the case, should we begin to think about alternative ways of using the PSA test? For instance, having age and ethnicity specific thresholds. So these are questions we hope to address in what I'll be sharing with you in terms of our next move. But first, what has been the impact of this study? This study was published in the BMC Medicine Journal, and it has since had over 170, it has been shared in over 170 media outlets around the world. I've been privileged to share this study with lots and lots of patient groups and charities, with the British Association of Urological Surgeons. The European Cancer Summit was held in Brussels and brought together cancer specialists, GPs, nurses, patient group, politicians. In fact, I was sat next to the Deputy Prime Minister of Belgium on the day. And so, he attracted quite a lot of people that matters in the world of cancer. I think perhaps the most important for us in the UK in terms of the impact of the study is the fact that the people behind policy are engaging with our findings. And this letter was sent to one of the major charities in the UK whilst they were, advocating for early diagnosis of prostate cancer. As you can see there, where I have underlined the minister's comments that researchers from Exeter basically are saying we should be cautious. So we were really, really pleased to see that the politicians are actually engaging, and they know that our study is suggesting that there could be overdiagnosis of prostate cancer in Black men. We should take this into consideration before hammering on screening for prostate cancer in men overall. So that's been the what we've seen in terms of this study. What we want to do next, I don't know how much time I've got. We've been
You've got
fortunate.
a couple more minutes, Tan, if you want it.
Okay, so yeah, I'll finish now. So we've been fortunate to I've been awarded and this is a fellowship for myself, the Wellcome Trust Accelerator Awards, to look at possible harm to Black men as a result of PSA or in prostate cancer diagnosis in general. I believe that once we are able to establish whether or not there is some harm to men from this ethnic background, then we will be confident on how we may use PSA better. Thankfully, we have the MRI to support men in their journey, but the PSA we know is widely available. And many countries around the world, if we look beyond the UK, may not be able to afford MRI as much as we can in the UK. So this study and the one that is coming up funded by Wellcome Trust is going to have some groundbreaking impact overall. I just want to finish by just showcasing some of the beautiful people that have supported this study. Sam Merrill from Manchester, Jessica from the University of Bristol, and some of my colleagues you'll be familiar with. But importantly, Mr. Alfred Samuel, who is not just a strong advocate for patients, is also a survivor of prostate cancer. He had stage 4 cancer and is still here with us and is supported us all the way. On that note, I'm going to say thank you once again for this opportunity. Thank you.
Brilliant. Thank you, Tani, and thank you for sticking brilliantly to time. I see claps coming up on the screen. Thank you for those. We've only got one question in the chat so far, so please do keep them coming. Jess, are you going to read out the question, or we're going to
I can read out the question.
Do it himself?
I'll read it out. That's fine.
Okay, thank you.
So Sam says, great talk, Tani. Younger Black men in their 40s and 50s are at higher risk of advanced prostate cancer compared to other ethnic groups at a similar age. Even though overall there was no significant differences between ethnicities overall, should guidelines for use of PSA by GPs be adjusted for this age group? What other evidence would be needed to inform the approach to prostate cancer detection for this group?
That is a very, very good question. Thank you. Yes, and I didn't go into that detail in my presentation. As a matter of fact, when you look at our findings, we noted that Black men under the age of 40 may have had advanced stage diagnosis. The problem with that particular group is the numbers tend to be very, very small. And so it is possible that our findings are due to maybe some chance, So what we plan to do in the Wellcome that we're taking forward is to actually look deeper. Because in that study, we actually looked at men from the age of 40. So what we are doing now is to look at men from the age of 18, adults, and just look at what is going on overall and see what numbers we've got and what it looks like. I think it is very, very difficult to change policy and say, let's target men under the age of 40. Again, I think the guidelines will have to take into consideration individual risks. So some people would know within their family that somebody's had breast cancer or prostate cancer. Maybe the guidance might be saying that, well, if you know you are particularly at the following risks, then maybe you should be asking your GP, because you have to take into consideration many men in that age range may just be single or about to get married, no children, and prostate cancer treatment often results in sexual dysfunction and etc. So it's a very, very delicate aspect that we need very, very robust evidence base before we start to consider any policy changes. We have to be cautious, very cautious, I say again.
Thank you, Tenny. We've got a couple of minutes, so I'm going to take chair's prerogative and ask you another question. And I was really impressed by the slide that you had about the kind of the reach of your impact, particularly amongst policymakers, including internationally. But it led me to think about how would you actually measure the actual impact of the work rather than the reach of the work, if that's a question. And perhaps that's best framed as, if in 5 years' time you could look back upon what this paper achieved, what would it be? And this harks back to the previous question a bit about, is it a change in thresholds for referral or normal ranges, or is it a change in NICE guidance, or what is it that you would hope to have achieved either in the UK or internationally from this paper?
I think
sorry, while you're answering that, can you take down your slides and we can get Adam ready as well for the next next slot?
Yeah, it's a tricky one, Richard, as you can imagine. A lot of advocates for prostate cancer screening. I think if we end up having an ethnicity specific threshold, then I think we would have made a lot of difference, because we then will have confidence that men that are referred, are referred properly. The current threshold we have, don't forget, are based on secondary care data. So what we've presented is based on primary care data, and what we're going to be presenting will use primary care data. And if that is taken on board, as you can see, the ministers are considering our work and they trust us. Even the charities are engaging with us. Prostate Cancer UK have rolled out a grant funding now to actually look deeper into some of the questions we raised across. So already, I think we've made a significant impact, and we're going to make more by the time we publish the next study. So if we can have ethnicity specific threshold, or say that it's not necessary, then I think we would have achieved our goal.
Fabulous. Thanks, Tanny. That's been really good and really interesting. And thanks for the engagement of the audience. We're now moving on to our second talk, and I'm delighted to welcome Adam Geraghty from Southampton, who, as you can see already, is talking about self-management interventions for chronic widespread pain, including fibromyalgia. And as before, questions in the chat, please. Floor is yours, Adam.
Okay, thank you. Yes, that's right. I'm going to talk about this qualitative systematic review we did on the self-management interventions for chronic widespread, including fibromyalgia. This work was really driven by Mio and Ben, and we worked with a fantastic team. Okay, so what do we aim to achieve? Well, chronic widespread pain, including fibromyalgia, is highly prevalent and can be really debilitating. When I say chronic widespread pain, what I mean essentially is pain across multiple sites of the body that lasts for more than 3 months. Increasingly, we're thinking about chronic widespread pain as on a spectrum now, and fibromyalgia represents the more severe end of that spectrum, with a core symptom of widespread pain, but additional symptoms, cognitive symptoms often, such as fogginess or fatigue. And as with other chronic primary pains, we're increasingly thinking about the role for behavioural self-management for these conditions as we start to pull back slightly from managing these conditions with medication. And when I say self-management, essentially I'm talking about interventions that aim to bolster skills and knowledge that apply directly to how to look after and manage yourself really and the symptoms in your day-to-day life. And critically, they teach you skills, the interventions teach you skills to apply beyond the intervention. So we've done some previous research doing a quantitative systematic review looking at self-management for widespread pain, and showed that it seems to be effective. It had positive effects on short-term and long-term outcomes on pain and function, but there was a lot of heterogeneity in that review, so a lot of variability between the interventions. That is, some interventions that were really quite similar worked quite well. Some interventions, which again were similar in terms of their components, didn't work so well. And the way to really address that, to be able to develop interventions and deliver interventions that are most likely to be helpful for most people, we have to understand how they work, all the key processes that seem to drive them. And to do that, we need to look at qualitative research. So our aim here was to systematically review the qualitative studies that have explored people's experiences of having taken part in these self-management interventions for chronic widespread pain. So what did we do? Well, it was a fairly standard systematic review at the front end. So we searched all the kind of key databases that you would normally. Those studies to be eligible had to be conducted with adults aged over 18. They had to explore a self-management intervention for chronic widespread pain, and they had to be qualitative. And we didn't include language restrictions. All the studies were kind of a standard double screened, and the data extraction was independently checked, and we praised quality using the CAST criteria. In terms of synthesis and how we brought these things together, we looked for common patterns using a thematic synthesis, an approach developed by Thomas and Harden. And really importantly, we had 3 public contributors involved throughout the process, and these were all people with lived experience of fibromyalgia, and they helped us with their grant application to the school who funded this work. They helped us with the protocol, and critically, they're involved in every step of the analysis and came to all our analysis meetings and supported the development of themes. So what did we find? Well, we found 23 studies, and our aim with these studies was to really pull out what seemed to be common key underlying processes that drove the impact of these self-management interventions. And I'll just talk through some of those briefly now. So these are multifaceted interventions, and they had a kind of a multifaceted response. And these kind of sub-themes within this first analytic theme are kind of driven together by a kind of an idea of alignment. So people often found that these tended to be personalized learning processes. So they're really made key and individualized for the person with fibromyalgia. And that was really appreciated. And I have a quote here from one of the studies that says, "I thought it was really good. It worked great because then I knew all the time that I had a plan and it was just for me. It didn't need to compare. I didn't need to compare myself to anyone else and so on. It was aimed just at me." There was also kind of an alignment between the health professionals because they had a lot of experience with chronic widespread pain, and people found that led to kind of emotional responses that were positive, and that was a key part. But interestingly, often these interventions included physical activity, which can be tricky in fibromyalgia because it can lead to slight increases in symptoms. So sometimes there was a misalignment with the kind of exercise demands of the interventions and what people were kind of willing to do. Another key kind of analytical theme was thinking about the groups. Most of these interventions were delivered as part of groups, and not for all, but in many of the studies, people found the group experience to be really quite transformative. There was a sense of kind of cohesion, and here's a quote here from one of the studies. Someone said, "You don't feel judged kind of in the group. I was putting on this poker face, so coming here, I didn't have to put on that face. I could be honest and say that I was in pain and how I felt." Kind of central to improvements from these kind of self-management interventions with this kind of new outlook that developed. People had a shift in self-awareness, so they became more kind of sensitive to what kind of triggered kind of pain, flares or fatigue, and critically how they might manage those themselves. And that led to kind of empowerment. One of the people in the study said, "It's good to know that the disease doesn't decide everything, and that I can actually decide some things as well and make decisions that affect the disease, that not only the disease affects me, and this means I have some self-control." People also talked a bit about acceptance and hope for the future. Not all, but some, and it was a key kind of factor. What an interesting finding from this review was that there was often these interventions are delivered over between kind of 6 and 12 weeks, and then they end. And although researchers might follow people up at 12 months, that people are kind of expected to kind of learn the skills and then develop them and apply them for the rest of their lives. And there was often a sense of a loss of support when the intervention period ended. So one of the participants in front of the study said, "I feel more and more that I am alone, and you get help to start a process, but not to continue it, and end up in the middle of somewhere, then it abruptly ends." And there are also complexities when people try to apply some of these skills that they'd learned in their day-to-day life. And so that's kind of an overall summary of what we found. And we feel that these kind of key processes that we identified can really support the development of both new interventions for widespread pain and fibromyalgia in the community and through primary care, but also adapting interventions that are already existing. So now to talk a little bit about the impact. So this systematic review was published in a leading pain journal, and I should point out that 3 of our co-authors there are our public contributors, and they had a really big impact on this study, and they talked about how the study had an impact on them, both on how they thought about their condition, but the positivity around being involved in a study that could or may well lead to impact for patients. One of our public contributors said, "It's been so interesting to be included in the public panel, and it's truly a pleasure to help in my small way to work towards a better understanding that could help lead to better care provisions for people experiencing chronic widespread pain." In terms of additional impact, Jen Pearson, who was involved in this kind of school-funded project, wrote this school-funded project into her application for an advanced clinical fellowship, which was actually to adapt ongoing NHS-delivered fibromyalgia intervention, and she was successful. So we're actually now working together to apply what we've learned from this systematic review to actually adapt an ongoing intervention that's currently kind of delivered across the areas of the southwest of the UK. This systematic review really was a kind of a kickstart for the collaboration between myself and Tamar Pinkers, who is a leading pain researcher here. And we've gone on to develop separate kind of interventions for fibromyalgia. And we've also developed an interdisciplinary pain research in pain theme for our Institute of Life Sciences, which is a scheme here at Southampton. We have over 100 researchers now involved in that, looking at developing new ideas to support people manage pain more effectively. And Kathy Price is a consultant in pain medicine who worked with us on this grant-funded project. And she included the grant-funded project as a key part of her application for an NHR Senior Clinical Award. We don't know the outcome of that yet, but we're hopeful that it might be successful. She's also since gone to become an Associate Professor of Pain Management and worked closely with our group. In terms of future impact, well, Jen Pearson's work is looking at using our review and some other things to make adaptations and improvements to an intervention that's actually already going on and being rolled out in the NHS. So we plan to, the things that are very clear that would improve the intervention, actually implement those, working with those that deliver that course right away. So we hope to have some direct impact on improving the offer there almost immediately. But then we also plan to kind of work with the team to develop applications for a randomized controlled trial of her optimized intervention, which the optimization being based on this grant-funded project. And then actually hope to work with other members of the school to build together a trial team where we could do a world-leading trial on this. And if we show that this intervention seems to be effective, then really push for national rollout. And I think I will stop there.
Brilliant. Thank you, Adam. Perfect timing and a lovely presentation. And I love the bits about impact at the end, which is what today is really all about. We have a question from Megan Armstrong, Jess.
Yep, and Megan says, great talk, thank you. How diverse was the sample within the studies? And do you think the components identified will be helpful for people experiencing socioeconomic deprivation who tend to be less involved and have less benefit from self-management interventions?
I think that's a really good question. So in terms of the diversity in the sample that was included in the review, it was relatively limited. Again, when we do these reviews, we're kind of limited by the recruitment strategies of the people who publish the papers. So that's a kind of a fair critique in terms of the studies that the review were based on. That said, in terms of the work that we're doing, in terms of how we apply those findings, we've got a really diverse panel who we're working with in terms of, the adaptations that we would make towards to the actual interventions that are implemented in practice. So we'd be able to draw on this kind of model that came from the review, but also make sure it accords and we implement it with agreement from diverse people from diverse backgrounds. And the second part of the question was around, can you mention the second part again?
Yeah. It was about being helpful for people experiencing socioeconomic deprivation who tend to be less involved and have less benefit from self-management intervention.
Yeah, I think that's a good point. And again, in the work that was kind of followed directly on from this that Jen Pearson is leading, we're doing lots of work as we kind of develop the amendments to the course to work with people from these groups to ensure that any kind of amendments have the potential to be effective. So we won't know about efficacy until we kind of study that separately with a diverse population. But certainly, I think if we develop them well enough and work with the people and kind of co-develop based on kind of things like the systematic review, but also outreach groups, that we should be able to make sure that anything we offered could be effective for these people too.
Brilliant. Thank you, Adam. One from me. I always hark back to when I was a very, very junior and naive GP, and I was doing a bit of research, and the senior practice at the senior part of the practice I was at the time was always kind of vaguely interested in what I was doing. And he said, Richard, what is it you're doing, what you're researching? And then I'd tell him that, and he'd said, well, what the use to me is that? And so it was always a challenge to me, and it was a really useful thing to happen, because he wanted me to tell him things that would help him in his work. So translating that to this, are there any because, and I ask this because people with chronic widespread pain and fibromyalgia can, from a clinician perspective, be quite difficult to manage sometimes, not always, but sometimes they can, because there aren't many therapeutic options and people are in pain and it's difficult. Are there any resources now that, can be shared with, your absolute regular job in GPs to actually help them in the management of these patients, to help these patients have better quality of life? Is there anything now that can be done?
Well, so this was a qualitative systematic review, so it's quite kind of downstream. Now, based on this review, we're working on things that are already implemented. So perhaps that's a slightly more difficult question to answer. But moving forward, the impact that we hope to get from this would be that your jumping GP would be able to refer into a more effective, management program that provides long-term benefit and helps these people in a kind of a detailed way. So this work is still is ongoing, but we're working directly, on the ground with interventions that are currently offered and can be referred into from primary care. So we're hoping that we'll be pretty quick to get to the point the GPs will have more effective treatments or interventions to offer this population.
Yeah, I mean, I think it's a really valid answer, and I think there's something on one of your next to last slide about engagement with NHSE or policymakers or something along those lines. And I think this is really what, research, school funded research is all about. It's actually funding this work to understand the evidence so that the appropriate services can be commissioned for the greater good of our patients. And if you can do that, and some of our patients with pain actually improve or get less worse because of that, then it's a good thing. But we must always keep our eyes on influencing policy, getting resources available, getting people to commission the right services, and so on and so forth. And I think this is a great contribution to the literature, and also the follow-on stuff will help that as well. So I never forget my colleague, the GP, that always challenges me on that. Good. I don't see other questions in the chat. So Adam, that was great. Thank you very much. That was brilliant. Ben, I can see you. That's terrific.
Thank you, Richard. Shall I go ahead and share?
Yes, please share. And Ben is from Kiel, and he's talking to us about the stoma support study. Sounds very interesting.
Thanks very much, Richard. So yes, our stoma support study, and this is the plain English title for the study. So helping young people with inflammatory bowel disease who've had stoma surgery to deal with distress. And just to give you sorry, I'm just moving the little pictures out of the way so I can see my slides. So just giving a little bit of background. So IBD, many of you will be familiar, refers to a group of conditions mainly affecting the small and large bowel, but can affect people from the mouth right the way down the gastrointestinal tract. The most common types are ulcerative colitis and Crohn's disease. And they have some similar symptoms. So things like abdominal pain, diarrhea, fatigue, weight loss clearly can be very debilitating for people who suffer from this. And for many people who have particularly severe IBD symptoms or symptoms that are resistant to medical management, they may end up having surgery to remove all or part of their large bowel, resulting in a stoma. And this is an opening in the abdomen through which feces are collected in a bag attached to the skin, as you can see in the image here. And stoma surgery for IBD is something that's a possibility faced by many younger people. And this is because IBD is commonly diagnosed between the ages of 15 to 25. And stoma surgery is most common in the first 10 years after diagnosis. And having stoma surgery can present many challenges for young people, but also presents opportunities for us to intervene and to try and improve the situation for these young people. So our previous underpinning qualitative research found that it was quite common for young people to experience emotional distress as a result of stoma surgery, which could be something that was short term, but also could persist and even worsen and develop into depression. And this was due to things like body image concerns, concerns around romantic relationships, social relationships, going out in public, impact on work or school. or just generally lowered self-esteem. And we found that actually this stoma-related distress isn't always discussed within healthcare consultations, or when it is, it's not always well managed. And also there was found to be a lack of age-appropriate resources, particularly online resources, aimed at this particular life stage or age group, that was specifically around managing distress and mental health needs. So in terms of what we did, we tried to address some of these challenges through working with young people who have a stoma due to IBD, as well as a range of healthcare professionals. So that included GPs, it included specialist stoma nurses, IBD nurses, gastroenterologists, and clinical psychologists who work with this patient population, to co-design an online resource to support young people between the ages of 16 to 35 to self-manage distress related to their stoma surgery. We're obviously focused here more so on impact, but I will briefly talk about the methods in the study. So this was a study that was carried out in 3 linked phases. So we did a rapid systematic review where we looked at interventions that had been developed and tested across a range of long-term conditions. So not just focusing on IBD, but looking at young people with a range of physical health conditions, and interventions that were specifically targeting psychological support or addressing the mental health needs of young people with these long-term conditions. And really, we were interested to see whether there was any sort of features or delivery or methods that we could adapt and that could incorporate within the resource that we were designing. The second phase was a consensus group study where we had a group of 19 young people with a stoma, and we wanted to try and agree what the content would be, what were the priority topics to be included within this online resource. And we used a technique called nominal group technique, very simple method that follows a set of structured stages. Essentially, the young people initially generated ideas for topics that they felt were important. We collated these topics, and then the young people voted on or rated rather on a 1 to 7 scale in terms of how important they saw each of those topics as being for inclusion. And then we averaged out those ratings and looked to see which were the highest rated and which had seemed to have reached agreement in terms of the topics that should be taken forward. And then we collated the findings from those first 2 phases, and they fed into some co-design workshops. So we had a series of 3 co-design workshops where we had a mixed group of young people with a stoma and health professionals, where we looked at these topics that had been agreed and what information, sort of decided what information should be included in relation to those topics, and also what the resource should look like, what features it should include, how it should be designed, how it should be delivered. So, really the young people we wanted to be central to this work and their views and perspectives, but also drawing on the views of a diverse range of health professionals across both primary and secondary care. And patient and public involvement was really central throughout these 3 phases. We had a really great group of 9 young people with a stoma who advised throughout. We also worked with national IBD and stoma charities to get their sort of advice and input throughout these stages. And in terms of what we found, so looking first at the rapid review, once we'd sort of whittled down and our eligibility criteria had been applied, 14 studies were included in the review, spanning a range of different physical health conditions. So in addition to IBD, there was epilepsy, asthma, type 1 diabetes, and a range of different sort of types of intervention or different modes of delivery. So some that were websites, some that were smartphone apps, some that were text message based, others that were workbooks or a combination. But actually of those 14, only 6 of those showed significant benefit in reducing young people's distress or improving their well-being. But actually, there were no differences found between those studies that were beneficial and those that weren't in terms of the features and the delivery of these interventions. So that kind of made it difficult for us to actually just, kind of identify what works and what doesn't. And really, that was where our patient and public involvement group came in really useful, because we looked at these results with them and looked at each of the studies, and they helped us to identify what may be the useful features and useful elements of design to take forward and to incorporate into our co-design work. In terms of the consensus groups, there were 7 topics that were agreed or reached consensus among the group of young people. I've listed those here. So the first was advice about romantic relationships, sex and intimacy. Secondly, and quite broadly, it was seen as really important that the voices of young people who had actually been through this experience were central in this online resource. The young people also wanted information about fertility and pregnancy related to stoma surgery, and guidance around processing the trauma related to what they've been through in their illness journey, as well as reflecting on the emotional response to having gone through stoma surgery. They also wanted inclusion of stoma hacks or sort of useful tips and advice around managing their stoma. So that might be things like how to make bag changes easier. And finally, they all identified managing the stoma during the night as being something they found quite problematic, and they wanted a bit of advice around how to manage bag leaks and things like this. And so this was fed into our co-design workshops, and the mixed group of young people and professionals decided that this should be in the form of a website, and it should really be sort of multimodal and including different types of media. So videos of young people telling their stories and sharing advice, health professionals providing information, infographics and diagrams, and also interactive features. So what we had from the end of this really was a detailed specification around what should be included in this resource and what it should look like and how it should be delivered. So to get on to kind of well, the important part really, the impact, and also where we want to go in terms of future impact. So clearly we've gone through this sort of usual dissemination in terms of publishing in academic journals, presenting at academic and healthcare conferences, and that's included including some of our patient and public involvement members as co-authors on that. But we've also wanted to try and reach a broader audience. So we've been engaging with patient groups and with young people with a stoma through social media. We've also been trying to engage with some of the groups that were less well represented in our sample. So, for instance, people from certain minority ethnic groups have been found to face particular challenges in managing a stoma related to their culture and religion. And so we've been particularly trying to engage with some of those groups around some of these findings, and discuss with them how perhaps we might look to tailor this intervention in the future to better meet their needs. We've also been disseminating through charities and talking to some of the national IBD and stoma charities about how to best engage with people. And that's included writing articles in patient association and charity magazines as well, to try and again engage with a broader audience. And in terms of what we want to do next, so we're moving on from the stoma support study to the stoma support study 2, where we want to take this intervention specification and work alongside web developers and continue to work with young people with a stoma, with health professionals, with charities, to build this online support resource. We'll then go on to user test the resource. So we'll ask young people to use it, provide feedback, and make changes based on this feedback, which will then lead to refinement and finalising the resource, and also developing plans to evaluate the resource to see if we can bring about changes to the mental health of young people with a stoma. And ultimately, we'd like this resource to be something that's freely available, that can be signposted to by GPs in primary care, but also stoma nurses, gastroenterologists, and something that in the future can improve the mental health and well-being of young people who have stoma surgery as a result of IBD. I hope I've kept within time there. I just want to acknowledge the research team, the study participants. I've mentioned our patient and public involvement group, who have been incredibly valuable in terms of their input and advice, as well as obviously the funding through SPCR. So thank you very much.
Brilliant. Thank you, Ben, and thank you for keeping to time, and thank you for a super clear presentation. And thank you also to you and to the other two for providing presentations of 3 very different studies with very different kinds of impact. Actually, it was quite it struck me how the main messages from these 3 studies are all quite different. Now, I did a little bit of homework before this session, Ben, and I found a really good video that you'd made, which I think is on YouTube, with 3 of your participants talking. So I don't know if anyone can find that and put it in the chat, because it's really worth looking at, actually. But one thing that really struck me, there was a testimony. It's only just a little thing. There was a testimony from one of your 3 young people in that video, who, before she had her stoma surgery, she did a lot of rock climbing, and she was really concerned that she actually wouldn't be able to wear the rock climbing harness. You know, these are first world problems, right? But really important to her if she had a stoma. And thankfully, she had the wherewithal to actually raise this as an issue before she had her surgery. So when she went for a pre-op with a surgeon and they marked her up for where they were going to site the stoma, they actually sited it in a position that wouldn't be affected by a harness, which I thought was just brilliant. And actually, there's then amazing pictures of her rock climbing. It's just one really small thing that's actually impacted her quality of life a lot, but only because she had the wherewithal to say that in advance. So there's something really important here about making sure that the touch points for your impact, the points at which people maybe are thinking about or surgery is being offered, or they might have to have it in the future, making sure that all the information is delivered at the right time, because it can clearly be delivered too early or far too late by the time they've had the surgery. I mean, the first stoma had been in the wrong place. She would have found it difficult with a harness, for example. So how do you negotiate that tricky issue about getting the touch points with the system right, so that people have the right information they need, and not just the technical stuff about how long they're going to recover from their operation, but the impact on their life, those 7 things that you mentioned. How are you going to ensure that they have that information at the right time that they need it? Sorry, that was a really long question.
Yeah, no. Thanks, Richard. That's really. First of all, thank you for mentioning about the video. And yes, that was another sort of part of, I suppose, a smaller impact thing that we did with our there were 3 members of our PPI group, and actually Megan, who you mentioned with the harness, she was actually our public co-investigator. So they were fantastic, and it's useful that you mentioned about that, because you're right when you say first world problems, but this is something that was really important to her. It was a hobby. It was something she was really interested in. It's obviously something that's important to her quality of life, and so these things are important to consider. And I think that's a really good point you made about the sort of the timing of the information and the touch points. And I think certainly this is something, and I guess I intend this resource and other support that we're developing to be, it's not something that's only going to be relevant to people, post surgery. It's not necessarily only going to be relevant to people immediately pre-surgery. When you're first having these conversations about potentially being a candidate for surgery, or it might be something you might have to consider in the future. For some people, some people obviously go through an emergency surgery. For a lot of people, it is elective. It is something that they might have discussions, several months in advance. And I think it is important to kind of consider some of these things and make sure that people are getting this information very early. And it may be that, and one of the ways that we hope to design this resource is that it's actually got perhaps information that's maybe relevant to people at different junctures. So it may be that there's certain information that you want and that you're ready for at that earlier stage, but you may not want to hit everything at that point, and there may be things that may be more relevant to people either immediately pre-op or post-op, or even further down the line. It may be that there's certain advice, certain support that may be more useful for people as they're starting to come to terms with their surgery. It might be several months after. So I think that timing is really important, and I think it's tricky, and it's certainly tricky from a healthcare delivery perspective. But I think it's really important to think about, certainly this isn't just something that is going to be addressed, when you're ready for surgery or getting ready, or post-operatively. It's maybe something that when you're starting to have those initial conversations, certainly from a healthcare provider perspective, I think it's starting to explore, okay, what are the concerns of the patient? What are the sorts of things that are important in their lives that they want to continue, and sort of trying to provide some of that effective reassurance around that.
And it's also something which spans different touch points within the health service as well. So some of it will be around kind of gastroenterology clinics, nurse-led specialist clinics, surgical clinics. You haven't mentioned the surgeons very much. I know they're just the technical people that do the operation largely, but they're important here. And the role of various people within in primary care, because people may come to us with those concerns about timing of stoma surgery and implications of it. And to be honest, most people in primary care haven't got a lot of experience of it. So it's the challenge you have for impact is getting your message across all those different sectors and at those different time points, so they have that information.
Yeah, absolutely. And I think that's one thing that we have found, is that perhaps in primary care, dealing with it may be that many patients do go with their mental health issues, of course, with distress, but there's then maybe not that specialist knowledge around stomas, whereas at the other end you've got the stoma nurses, for instance, who are very familiar with the practical issues around stoma care, but we've identified that they don't feel that they have necessarily the formal training around dealing with mental health issues. So there are those kind of gaps at various points across the pathway that absolutely yes, are important to address.
Good. Well, I was enjoying a nice private conversation with you then, but we now have a question from Rita as well. Do you want to read that out, Jess?
Yeah, Rita asks, is IBD happening more in females than males? The participants in the video are all females.
Yeah, that's a good question, but I think I mean I think that's an issue we often get in this kind of research is it's harder to engage, especially with younger male participants, and I think that spans not just IBD and stoma but lots of different health conditions, and so that was something that unfortunately we did end up with a sample which was not as representative as we would have liked. So we did have a lot more female than male participants. We did have mostly white middle class participants, so we weren't able to get a lot of representation across sort of socioeconomic lines, and that's something that we are trying to address going forward. So I've been doing some engagement work where I've been trying to engage more with younger men, also with been talking to some groups from sorry, this wasn't your question, but talking to some groups from sort of different minority ethnic groups, for instance. I think members of the LGBTQ plus community, I think, is a really important issue around this as well, because stoma surgery has particular implications around romantic and sexual relationships, and we were actually able to have some good representation in terms of people who did identify as LGBTQ plus. But yes, I think the issue really probably was more with our engagement and recruitment rather than actually in terms of the stats of which gender is most prevalent with. But that is something we're trying to address in terms of engaging more with younger males in particular, because I think their perspective is clearly going to be very, very important going forward.
Thanks. I've got a quick question, if it's all right.
Yeah, go ahead.
Richard. It's really about social media, which you mentioned when you were kind of talking about the impact of your first study, but obviously the next step would be to kind of build the platform, and then you'd want to get that out there as widely as possible within this young kind of target population. And I was wondering, as a researcher, how much support you have had so far to kind of do that social media engagement, or what to kind of utilize that impact, or what strategies you would use.
Yeah, sure. So a lot of it has so far been through. So we've had some engagement with social media influencers, actually, and sort of bloggers who work in this space, who have been really useful, and groups, sort of social media groups that are set up for IBD support, for stoma support, have been really useful in getting the message out there, and engaging with the charities and their social media platforms have probably been the most useful. But yes, absolutely. There's going to be a range of avenues that we will explore in terms of disseminating this, but obviously social media is going to be one of the key ones, absolutely, moving forward.
Great, thank you. So I don't see any more questions, so I think we're probably gonna close now. Firstly, can I thank Tanny and Adam and Ben for fabulous presentations and delivering them really well and focusing on the impact questions, which have been really interesting to discuss, because they've presented different kind of challenges to us. Thanks to Jess for coordinating and helping with the operation of the showcase, and thank you all for listening and for your questions. I see lots of love in the chat. That's great. And the next one is what, in a week or two, Jess? Do you know when it is? I can't remember.
We actually have one on Wednesday.
Have one on Wednesday.
We have one on Wednesday, so please do come along. You can email us if you've lost the link. But yeah, please do come along and listen on Wednesday.
Brilliant. So thanks again, and hopefully see some of you on Wednesday. Thank you.
Thank you.
Thank you very much. Bye.